At this stage, we're going to go to the opposite end of the spectrum. So it's really a pleasure to introduce Dr. Diana Thiar, who's going to be talking about the overweight patient and how do we optimize that patient for surgery. Thank you.
Hi, everyone. It's a pleasure to be here today. I'm a general internist and obesity medicine specialist. I run the medical weight management program at UCSF as well as our obesity medicine fellowship. Here are my disclosures. In terms of objectives, in this brief overview of how to treat obesity, which is a huge topic, I want you all to walk away with a really high-level understanding of how we think about treating obesity with different pillars. I hope you can walk away knowing the 6 FDA-approved anti-obesity medications for long-term use, understand these GLPs, which are not a trend or a fad, but really paradigm-shifting how we can care for people with obesity in the long run. And then understand the role of these GLP drugs in not just treating obesity, but the comorbidities associated with excess body weight. So I always start these talks with understanding what is our goal. When we think about treating obesity, our goal as medical professionals is not to hope that everyone looks the same. This is a room of very fit people, and I suspect, in your field, most people do look a certain way. But when we think about treating obesity, we want to help prevent morbidity and mortality associated with that adiposity. We don't want people to think they have to look a certain way to be valued in society or to be cared for by us as medical professionals. The other thing is that we shouldn't always assume that just because someone has excess body weight that they are unhealthy, but we do want them to understand the risks of long-term adiposity for health comorbidities. We also know that modest amount of weight loss can improve health. With 5 to 10% body weight loss, we start to see clinically meaningful changes in things like prediabetes and hypertension. And it's really above that 15% body weight loss mark that we start to see remission of some of those cardiometabolic diseases like diabetes, cardiovascular mortality, as well as HFpEF. While BMI targets drive a lot of what we do in medicine, we don't necessarily want to fixate on this idea of a normal body weight, because we know that it's really percentage change in someone's starting weight that can improve their health risks. It's not taking someone with class 3 obesity and getting them to an overweight BMI. It's trying to get someone that 15, 20% body weight loss to help them have a longer, healthier, more robust life. The other really important thing to note is as we think about treating obesity, we have to think about it with the perspective of any chronic disease management. If we take away the intervention that's treating our patient, that chronic disease will come back. It's the same case with obesity. When it comes to spinal surgical risks, we do want to try and optimize BMI and weight if possible. We know that there are higher risk of postoperative morbidity with a BMI over 30. And with anterior lumbar interbody fusion, the risk is really at that BMI over 31. And what are those risks? You all know this better than me, but it's things like surgical site infection, postoperative VTE, ileus, and UTIs. But on the other side of the coin, we also know that people have really improved functional outcomes post-op at any BMI. So we want to use our clinical decision-making and not be too rigorous and restrictive around the BMI cutoffs as we're thinking about how to treat our patients. Historically, as we've thought about treating obesity, we've thought of it as this pyramid. At the base of the pyramid, we have our primary care providers who should really be treating people with lower BMIs in that overweight category. As BMI increases and risks of comorbidities associated with excess body weight also increase, we have obesity medicine specialists like myself. At UCSF, we have a comprehensive care team of dietitians, physicians, nurse practitioners, behavioralists, and we focus a lot on the pillars of treatment: lifestyle change, which is diet, exercise, as well as anti-obesity medications. At the top of the treatment pyramid is surgery, but you have to remember that just because we have this escalated approach and options for our patients, we have to really follow what they want for their treatment protocol. Just because we have powerful medications or we have surgeries that work, it's really important to provide patient-centered care and patient-centered decision-making so the patient feels respected in whatever they decide to do. The other really key thing is that taking a medication will help people lose weight, but it's not going to teach people how to eat healthier or move their bodies more. So lifestyle change really matters. We want to make sure our patients are eating enough protein. It's a really big focus right now. I mean, at Starbucks, you can get a protein foam. But the reality is in the US, the average American meets their protein requirements, and it's the fibrous foods, vegetables and fruit that are lacking. So as we're counseling our patients to up their protein, move their bodies more, you also want to make sure they're actually getting the micronutrients through proper vegetable and fruit intake. There are currently 6 FDA-approved medications for long-term use in obesity management. The first 4 are sort of the older class of medications, and the last 2 are the newer generation of meds that we use. So we have orlistat, which is a lipase inhibitor. It's not very effective at only 3% body weight loss. The next is Contrave, which is a combination of bupropion and naltrexone, which is an oral pill, and you can see 5 to 8% body weight loss at 1 year, but there is some weight regain at year 2. The third is Saxenda, which was the first injectable GLP medication FDA approved for obesity management, and this was in 2013. 5 to 10% body weight loss at year 1 with maintenance of only 6% at year 2. Qsymia is an oral combination of phentermine and topiramate with 9 to 14% at 1 year, but again, some weight regain at 2 years. And then 5 and 6, what you can see is different, is with semaglutide 2.4, we have maintenance of that 12.5% at 2 years. And then with Zepbound, which is tirzepatide, we actually see more weight loss at the 88-week mark. Why does that matter? Maintaining weight loss is how we actually can improve morbidity and mortality. So numbers 1 through 4 have a certain amount of weight regain, which suggests in the long run, our patients are not going to have reduction in cardiovascular disease, sleep apnea, and things like that. But it's really this newer class of medications that everyone's hearing a lot about that are helping people lose weight, keep it off so that they don't have things like heart attacks, strokes, progression to diabetes, and so on. So why are these medications so powerful? It's because they act both centrally and peripherally. So we as humans evolved to have our hunger and satiety signals regulated in the hypothalamus, a very complex set of feedback loops between the gut hormones and the brain. But we all know that we eat now for reasons that have nothing to do with our energy homeostasis. So historically, medications only worked in the brain. Things like topiramate, bupropion, naltrexone, phentermine, they act in the brain to reduce those hunger noises, increase dopamine, and reduce cravings. But our brain is very powerful and can do things that outperform what is happening there. So people feel the effect for a couple months and then they go back to their favorite restaurant or watching their TV show with their partner or whatever, and those food signals start to come back. But what GLPs do is they do continue to act centrally on that POMC-CART mechanism to promote satiety, but they also act peripherally. So they act in the stomach to decrease gastric emptying. They act on the pancreas to increase insulin secretion, which is why these are so powerful for people with diabetes, and they also act via the liver to improve insulin sensitivity. GIP has an added benefit of increasing lipolysis and fatty acid synthesis. So it's important to note that semaglutide is a GLP monoagonist, and then tirzepatide is a novel dual GLP-1 GIP agonist, and it is way more GIP agonizing than GLP agonizing. So it's only about 1/8 the GLP receptor agonizing as something like semaglutide. So while they are similar medications, we can't just call them the same thing. It's not like 2 statins. They're not interchangeable in that way. The side effects coincide very closely with the mechanism of action. So nausea is very common, especially at the beginning and with dose up titration. It's really important to note that being so nauseous that you can't eat or throwing up so regularly that you are having signs of malnutrition, that's not normal. Our goal is to promote a healthful lifestyle. So if someone is so sick that they're not able to go to their kid's soccer game or get out of bed and go for a walk, this is probably not the right medication or not the right dose for that person. The other common side effects are on the opposite end of the GI system, things like diarrhea and constipation. Those are managed very well with added fiber supplements, even in your patients who are taking in a lot of dietary fiber. Adding in a daily supplement can help. We also sometimes see things like fatigue, headaches, oftentimes associated with low PO intake or dehydration. And the rare but serious side effects are things like pancreatitis and cholecystitis, seen in less than 1% of the study population. Suicidal ideation was not seen in the RCTs, but in the post-hoc FDA reporting, some people have reported it. It has not panned out in looking at the secondary studies, but we still bring it up with our patients just to make sure they're aware that mood changes can occur. There are two absolute contraindications to use. One is personal or family history of medullary thyroid cancer, or MEN type 2. This contraindication has given the entire class of medications a black box warning, but it's important to note that these effects were seen on rat thyroid studies, and the rat thyroid is not a good human surrogate. So we haven't really seen it pan out, but we're also very vigilant about screening for these personal or family histories before initiating drug. The other thing is that this class of medication is contraindicated for use in pregnancy. It is not a teratogen, but it does increase fetal loss through placental disruption. So it's important for our patients who are trying to get pregnant, actively trying to get pregnant, to understand their risk and come off the medication before trying to conceive. I think the other side of the coin is that we've actually seen increased fertility rates and accidental pregnancies in women on these medications, because with weight loss, we see more better reproductive ability. So as we counsel our patients, we tell them of the risks, but also sort of the reality that it's still possible. In terms of the results, we talked about what it looks like at 1 year, but what's really key to note is that for both classes of medications, there are hyperresponders. So for semaglutide 2.4, about a third of patients had over 20% body weight loss. And for tirzepatide, over a third of patients had more than 25% body weight loss. That's the low end of a sleeve gastrectomy. So something like tirzepatide in these hyperresponders could be a quite powerful medication that's nearing what we can see with surgical interventions. And how are these medications used? They are single-dose pens that are weekly injectables. You can up-titrate in 5 months, but you don't have to. So if a patient is having a lot of side effects, you can spread out the timing between injections or wait 2 months, 3 months before up-titrating to make sure they feel better before you go up on a dose. So how do you think about this? If you have a patient who's about 250 pounds, 5'11", that puts them at a BMI of 35, which is class 2 obesity. To get below that BMI of 30 to decrease those surgical risks, that patient would need to lose about 14.5% of their body weight. That's higher than what we would expect with something like semaglutide 2.4 for the average person, but it's definitely within range for something like tirzepatide. Now, what is the time course of this weight loss? If your patient needs a surgery, but they have to lose weight beforehand, unfortunately, it is a quite long duration. So we see max weight loss around 68 weeks for something like semaglutide and closer to the 88 weeks mark for tirzepatide. So this is something that requires planning. If your patient urgently needs a procedure, bariatric surgery will be a quicker way to get weight loss. We see those rates of weight loss really peak around 6 to 12 months for surgery. So that's an important thing to remember. The other thing is that we know when these medications are taken away, people regain their body weight back. So both with the STEP 1 extension trial and SURMOUNT-4, both studies had slightly different designs, but when patients were removed from drug, maintained on lifestyle change, they regained 2/3 of their body weight back. Now that matters both clinically because you're taking away all those potential benefits, but the reality is that that person's body composition has also changed. When we lose weight, we lose fat and a little bit of muscle, and that's okay. But when we gain weight, it's our adipose reserve that grows. So when that patient gains 2/3 of their body weight back, that's all in their adipose tissue. And so now their body composition profile has changed to be more fat and less muscle than before they had initiated therapy. And that's what's key. We know that women are likely to be in that hyperresponder group, specifically for tirzepatide. So with the tirzepatide SURMOUNT 1 through 4 trials, they did sex-specific weight loss trends. And what you can see is that women were on average losing closer to that 24, 26% body weight loss, where men were lower, closer to the 15 to 20%. And when you further subcategorize this based on hormonal status, it's really premenopausal women that are losing the most amount of weight, and they're losing a lot of visceral adiposity. So premenopausal women are having really profound metabolic changes with this medication. It's also important to know that they could be hyper-responders and overshoot the mark. So you want to make sure you're treating your patients very carefully with these medications so they don't lose too much weight and become malnourished, as you had mentioned. I'll be very brief. You have these slides in case you want to unpack the data here more. But my goal as an obesity medicine provider is not to treat someone because of the way they look or just to help them lose weight. It's because we know that treating obesity can treat all of these other cardiometabolic and mechanical diseases. So by treating this one condition, we can really knock out all of these other things that really reduce people's quality of life and their lifespan. There are really three main trials that you all should know about that have shown reduction in morbidity and mortality and have gotten secondary FDA approval for these class of medications. The first is the SELECT trial. It was the first trial showing a medical intervention for obesity that can reduce MACE risk. So this was a very large study, 17,000 participants with a BMI over 27 and known ASCVD defined as MI, stroke, or PAD. Why does that matter? Because the FDA shows really high fidelity to study design for obesity. And so the patient has to have MI, stroke, or PAD as their ASCVD diagnosis, not just an elevated ASCVD risk, hyperlipidemia, hypertension. None of that works. It's very clearly these three indications. This was about a 4.5-year study. People lost about 8.9% body weight at that 5-year mark. And what you can see in box A is that there was a 20% risk reduction in the primary composite endpoint, which was the combination of time to first MI, stroke, or death from any cardiovascular cause. Metformin for diabetes has about a 20% MACE reduction. So this is a really profound finding. For tirzepatide, they're doing the trials right now. We're hoping to see that data come out in early 2028. Unfortunately, there's not just a class effect FDA approval for this cardiovascular outcome, so they're going to have to study this for every medication that comes out. The other big trial in the space is SURMOUNT-OSA, which is looking at tirzepatide for OSA. And in this patient population, it's people with a BMI over 30 and moderate to severe OSA, defined as an AHI greater than or equal to 15. Again, a large trial. And over the course of the year, people lost around 18% of their body weight and had a profound reduction in their AHI by about 50%. And almost everybody in that moderate sleep apnea group went to either no sleep apnea or mild, and even in the severe group, over half the patient population regressed to the mild or no sleep apnea. And it's this SURMOUNT-OSA trial that got tirzepatide's secondary indication for use in obesity plus moderate to severe sleep apnea. Again, very strict with that definition of BMI and AHI cutoff. And then the third is the study in MASH with semaglutide 2.4. It's the ESSENCE trial. It was a very long study, 240 weeks. It's ongoing, but they published their 72-week data because it was so powerful. It showed pretty significant improvement in steatohepatitis with no worsening of fibrosis, and also reduction in fibrosis with no worsening of steatohepatitis. This got FDA approval in August for semaglutide 2.4 with MASH in the absence of a BMI cutoff. So that's pretty important because it isn't necessarily just related to obesity. Any of our patients with MASH can now get semaglutide 2.4. The insurance companies are still requiring a lifestyle change component, and they are requiring a specialist be involved in the care. So there is a lot of gatekeeping around these medications that is frustrating and really limits our ability to care for all of our patients appropriately. There are other trials that have been done looking at knee OA that have shown improvement, but no FDA indication for that. And then there are tons of other things being studied, and I'm sure you all see this in the news or on social media or hear it from your friends, family, anybody, but they are looking at these medications with substance use disorder, and they have been very powerful in animal models. We're seeing more data come out in dementia, Alzheimer's disease, and Parkinson's disease for these medications in diabetes, and they are now doing prospective studies for obesity. We're also looking at these medications for autoimmune disease like psoriasis, RA, IBD, and then a lot of the reproductive hormone diseases like breast cancer, HS, and then also separately in the cardiovascular space, we are looking at these for AFib. And then as a San Francisco person, I call this space the gold rush because there are tons and tons of medications that are being studied and will likely come on board in the next 10 years. What we will probably see in the next year are the oral GLPs. I'm sure you all saw the news about Orpho getting fast track approval, and then we have high-dose semaglutide as well. There are other dual agonists that are being studied, things like GLP amylin and GLP glucagon. There's a very powerful triple receptor agonist called retatrutide that's completing phase 3 trial. And then we have completely other mechanisms of action with the activin receptor inhibitors that are looking at promoting muscle growth. So this is a very rapidly evolving space. It'll give me a job for the next 10 to 20 years, but it's really important for everybody in the medical community to be aware of how powerful these are, how well they work for the right patient, because it's probably the most popular thing in medicine right now, and everybody's going to be asked about it. And with that, I'll leave time for questions.
Thank you, very helpful. Question about, there's not necessarily a outside perspective on demonstrations, but is there like a one-two punch in terms of, like surgery would be in a room environment, gastric sleep, and then you couple that with GLP-1, for example? Is there one procedure that you prefer or that you see more success in?
Because of all of the supply chain issues when these medications came out, there have been massive delays in these secondary studies. So the question is, should surgery or a procedure happen first or the medication first? And I think you can probably expect that the internists say medication first and the surgeons say surgery first. But then there's also this third procedural group, which is endoscopic. So I think, an endoscopic sleeve with a medication for your patient who has class 3 obesity, but still 40 to 50 is probably a reasonable approach if you need an intervention quickly. But if someone has a BMI over 60, I do think that bariatric surgery is probably the better first line. Some people are not having the same response, and we wonder if there is so much adiposity that there's not the correct bioavailability of the drug. But you really have to go with what the patient wants. And everyone has a weight story. If you're thin, if you're not thin. And so this is one space where it's important to tell your patients all of the pros and cons and say what you personally would do if they ask. But at the end of the day, you have to go off what your patient wants because everybody has a story.
Do you have a knowledge of what percentage of bariatric surgery cases, like how much they've gone down, let's say in the last 5 years? And do you think there will be any bariatric surgery left 5 years from now?
There's no data that I'm aware of. I don't think they would want to publish that, but the BMI criteria did go down in 2021 at the same time that Wegovy was FDA approved. So there's clear signs that the higher cutoff wasn't going to be enough of an output. In the Bay Area, I don't know how many people are Bay Area people, but bariatric surgery is not super common, but in other parts of the country, it still is. And a lot of medical weight management is housed within bariatric surgery. So I think there's definitely a home for it. I personally think that the laparoscopic procedures will potentially gain in popularity if academic centers, gastroenterologists are able to build up that practice because they just have fewer side effects and less sort of long-term issue with malabsorption. So the malabsorption after bariatric surgery is the problem. And the problem is not that we don't know how to treat it. It's that patients stop taking their multivitamins. They graduate to their PCP, they move to a different state, and people just totally stop tracking all of those deficiencies.
Thank you for your enlightening lecture. I think this is really refreshing. It's a paradigm shift from where we were 10 years ago. And it's great news. I'm just thinking long term. You mentioned that if they come off, they gain 2/3 of the weight back, and it's not healthy because it's mostly adipose tissue, not the muscle is the hardest thing to build. And we talked a lot about frailty today. So can you give me an idea what happens to these patients long term? They just are on maintenance drugs forever, or I have no idea. So can you enlighten us on that?
It's a tricky question. Some real-world data is showing that with intensive lifestyle intervention, people can maintain the weight loss, but the question is for how long. When we look at other data that we have from previous medications, there is a subset of patients who can keep their weight off. And what we know from sort of correlational studies is that really high levels of activity and doing ongoing monitoring of your food intake is what's going to keep you most likely to only regain less than 5% of your weight back. We live in a healthcare system where insurance changes a lot, both what they decide to cover, but also each individual's insurance plans when they switch jobs. So people can't stay on these drugs indefinitely in the current ecosystem. And so what we try and do is say, let's go down the way we went up. If your hunger noises increase, if you start gaining a lot of weight, we either need to put you on a different class of medication, or maybe you should do something like surgery. But we follow those patients really closely. And when they start to gain 5, 10 pounds, they know to come back to us. That is not realistic in the primary care population, though. So I think there has to be a bigger shift around how health systems can provide this wraparound care for people who have obesity.
What's the idea around this hypothalamus reset that I read about? And again, I'm not even 10% as smart as you. So I read that that a lot of this is resetting the hypothalamus. So is it that once the hypothalamus doesn't see the drug, it goes back to where it was?
So people who have chronic obesity, the thought is there's a couple things going on. One is that there's a hypothalamic dysregulation. The other is that we know through both fMRI studies and other MRI imaging that there's a different response to dopamine in the brain. We don't know if it's less of a dopamine release or if it's decreased dopamine response in the brain, but it's a combination of both. And so with the medications, we do see some improvement in that hypothalamic response because the GLP receptors are being activated more. But I just was at Obesity Week this week, and what we saw in the fMRI studies is that even with that weight loss, there isn't an improvement in dopamine response, at least in the short term. We don't know years 5, 10 are people who lose weight, do they have that improved dopamine regulation? But it's really disheartening to see that that doesn't happen. And that food noise is what is really troubling for people when they lose weight, and that's why it's so hard to maintain it. So if you come off the medication and you lose that hypothalamic benefit and your dopamine response system hasn't changed, you're really just going right back to where you were when you weren't on the medication. That being said, people who don't have chronic obesity, so think about that person who gained a lot of weight during the pandemic, they might not need such a long-term intervention, and they might also benefit from trying some of the earlier class of medications first.
Just with regard to bone health, this ties in importantly. One of the patients that I treated, a young male in his 40s who had had a gastric bypass about 10 years earlier, and you talked about supplementary vitamins and things. He had not been taking that and had perhaps one of the most severe cases of osteoporosis that I've seen. How do you monitor that over time? I've seen two people with bypasses, one with a copper deficiency that resulted in neuropathy, and one with pretty severe osteoporosis.
It's really unfortunate because what bariatric surgery does a great job following their patients, but you all understand that there's a maximum amount of time that it makes sense for a patient to stay with you. Very few PCPs in my own practice, which is a high-functioning academic practice, know how to do the labs. And the other thing is patients, they don't even tell their doctors. I just got a transfer patient. I do primary care as well. She never mentioned to me she had bariatric surgery, but I knew because that's my job. But the fact that the patients don't tell their doctors, the doctors don't know what to check, it leads to these really intense complications. And I also think, this is anecdotal, younger patients are not as good about staying on medications in the long run, whereas an older patient who already has some chronic disease and is used to taking a medication, they do it regardless of if they feel any different. And so that's really the tough part about having a young person have a surgery that requires labs twice a year, multivitamins for their entire life, and making sure that they're really staying connected in the healthcare system and also advocating for themselves.
All right, well, thank you again. That was really amazing. We appreciate you.